I'll be going over triple rule out for the next half an hour. I do not have anything to disclose. I did not receive anything from Philips. I hope to receive a shirt from the SDR but when I return my evaluation, and I do have an accent, so those are my disclosures. So the learning objectives, or what I'm going to try to go over, is first an overview of chest pain in the emergency department setting, the indications for triple rule-out CT, the limitations of such examination, how to optimize the protocol to reduce the radiation exposure and the contrast dose, and a quick review of the literature to know what's out there. Chest pain is the most common presenting symptom in the emergency department, and in the US alone, approximately 6 million of patients present yearly to the emergency department complaining of chest pain, and that leads to more than $10 billion spent in the evaluation of these patients. There are several causes of chest pain. The immediate life-threatening ones are acute coronary syndrome, aortic dissection, and pulmonary embolism. Most of the patients who present to the ED with chest pain actually do not have acute coronary syndrome. Only 10 to 20% of these patients will have such diagnosis. But on the other hand, almost 10% of the patients who do have acute coronary syndrome are going to be misdiagnosed and inappropriately discharged, leading to double mortality. And the patients in whom this diagnosis is missed tend to be young patients with atypical presentation, non-diagnostic EKG. So if you have a patient with a typical presentation, precordial pain radiating to the arm, to the jaw, you have ischemic changes in the EKG, elevated biomarkers, it's no-brainer. You're going to go admit the patient, and the patient should go to the cath lab with some kind of intervention. When you have a patient where you suspect the patient may have acute coronary syndrome, the standard of care is to do serial EKGs, serial biomarkers, and stress tests. And that was leading to our healthcare costs very high, $8 billion a year. And of those $8 billion, $6 billion was spent in negative cardiac evaluations. That's when radiologists and cardiologists got together and tried to come up with the coronary CTA as a safe, efficient method to triage these patients that have low to intermediate likelihood of having coronary artery disease. And there are several papers out there that already prove the diagnostic value of this exam. For pulmonary embolism, as we all know, chest CTA is the standard method used to evaluate these patients. The same thing with aortic dissection. If you have a hypertensive patient with chest pain radiating to the back, unequal blood pressures in the upper extremity, you should go ahead and do a chest CTA with a protocol for dissection. So if you have classic cases, you have suspected acute coronary syndrome, you're either going to go to the cath lab and do a coronary CT. If you're suspecting PE, you do a PE CT. If you're suspecting dissection, you go a gated CT dissection protocol. The problem, if you may say, comes when you have atypical chest pain and you are not really sure what's going on with the patient. So if you go from your right-hand side to the left, you have to think about what are the possibilities on this specific patient, what can be going on. If you think the patient has a pretest likelihood of having pulmonary embolism and dissection, but you're not thinking about coronary syndrome, you shouldn't do a triple rule-out. You can do a prospectively gated dissection protocol and extend your bolus of contrast to pacify both circulations. You can even do a non-gated, many places do a non-gated CT for dissection. As long as you have a longer contrast bolus, you're going to be able to pacify both circulations at the same time. If you think the patient may have acute coronary syndrome and dissection, excuse me, you can do a cardiac CTA and extend your field of view to the level of the arch to look for dissection, but you're not really thinking about PE. And the topic today is about triple rule-out. So if you think the patient might have acute coronary syndrome and dissection and PE, one of the three or all of the three, for the matter of it, you should do a triple rule-out CT. That's the indication. An example of that would be if you have a 37-year-old female, she's obese, she's presented with acute onset of non-specific chest pain, she's a smoker, hypertensive, she's on oral contraceptive, she doesn't have any past medical history, she never had an infarct, no stents, no CABG, but her mother died at a young age of 50 from an MI. She had a recent long trip, airplane trip, just let's say she came from Brazil to the STR, and you did a first EKG, it's normal, you do a first set of enzymes, and it's normal. That's the ideal patient. She has risk factors for the 3 diseases, and you want to rule out the 3 diseases, so instead of doing 3 tests, you just do 1 test and rule out everything. So it's essential to have a careful patient selection. It's indicated in patients where they have atypical chest pain and you are suspecting they have a reasonable pretest likelihood of having any of the three diseases. Okay? So if you're thinking one only, you go ahead and do the dedicated CTA, but not a triple rule out. And why is triple rule out good? So it can identify these three most common life-threatening causes of chest pain, but can also give you an alternative diagnosis, such as pneumonia, pneumothorax, rib fractures, diseases in the thoracic spine. You imagine the entire chest, so you also get a sense of what's going on. Even if the patient does not have any of the three diseases, you may find another reason for the pain. So let's say you have a patient and you decide, okay, this patient has a acceptable pretest likelihood of having the three diseases. You have to be careful for patients who will not benefit from a triple rule out. So for example, if the patient is unable to hold their breath for 10, 15 seconds, you shouldn't be doing it in the first place because you're going to have respiratory motion and it's going to be a non-diagnostic test anyways. So what's the point of doing it? So the patient has to be able to hold the breath for about 15 seconds. And the other things you have in the bottom here are the same that we think about when we are going to perform a coronary CTA. If you have an irregular cardiac rhythm, patients with atrial fibrillation, multiple PVCs, or if you have a high heart rate, you cannot give beta block, or in patients who have a high likelihood of having coronary disease, the chances of getting all calcification, you're not going to be able to look at the stenosis anyways, so they should not have the coronary CTA part of the study anyways, so it's not going to be a triple rule out. So you decide the patient is not part of those, and you have, so the moment you decide I'm going to do a triple rule out in this patient, you need to prepare the patient. The same way you prepare a patient for a coronary CTA. If you have a high heart rate, you're going to give, it's better to give oral beta block 1 hour before, just because it stabilizes the heart rate better, but you can give IV beta block if there is an emergency and they want to have the study done sooner than later in the table. Usually we give sublingual nitroglycerin at the scanner so we can dilate the coronary arteries and have a better look at them. You need at least 18-gauge needle, a good peripheral venous access, so you are able to inject at a 4.5 cc's per second rate. Like any CT, you have to look for allergy to contrast and consider pre-medicating the patient depending on your institution policies. And if the patient is pregnant, of course, you're going to assess risk versus benefits of the radiation. You have to have in your institution the technology to do a triple rule out. So you need at least a 64 slices multi-detector CT. And the reason for that is that we're going to scan the whole chest in a gated study, more likely to be retrospective. I'll go over the gating. But it's going to be a long study. It's going to be 15, 20 seconds. So besides Michael Phelps, I don't know, I can hold for 20 seconds. So you have someone, if you have a 64 multi-detector CT, you can do it 50 seconds. But if you have a 16 multi-detector, it's going to take like 30 seconds to do the whole chest. And I don't think anybody can do that. Your scan has to be able to do ECG gating, of course, and it's preferable to have tubal current modulation, some kind of another technology to reduce the radiation. You need a trained technologist, and you need a radiologist on site to monitor the study most of the time, because to help the technologist to prep the patient and so forth. And you need the radiologist to be trained in cardiac imaging to look at the coronary CTA part of the study. When you go ahead and perform the study, you can think about, you could do a calcium score, which is an unenhanced CT of the heart beforehand to look for calcification. And if you think the patient may have a lot of calcification, you do that. If the patient does have a lot of calcification, you don't do the triple rule out, you just do a double rule out. You look for PE and dissection, but it makes no sense to do the coronary CTA part if you're gonna have a lot of calcium there. And it's proved if you have a calcium score of 400 to 1,000, it's usually non-diagnostic, the coronary CTA. It does not correlate well with CAT findings. What we do a bolus timing with 20 cc's of contrast, and you see how long it takes to opacify the ascending aorta. Then you go ahead and you do a ECG-gated chest CTA from the thoracic inlet to the diaphragm. And what we do, we continue with a non-gated abdominal CTA to look for extension of a dissection. What can be done here is if you are at the scanner and you scan the chest and there is no dissection, you can stop and don't do the abdominal part, because it's much rare to have isolated abdominal dissection. So if you did the chest part and you have no dissection, many people don't see a reason to do the abdomen. And the other debate that exists in the literature is if you should do an acquisition that is cranial to caudal versus caudal to cranial. And people who favor the cranial to caudal is because the heart rate is more variable. The first moment you take your breath in, the heart rate is a little unstable and then stabilized. So if you're acquiring from the thoracic inlet down, by the time you reach the heart, your heart rate will be more stable and you get a better ECG gating. The other reason is that pulmonary circulation enhancement happens before the aorta, so you can start scanning the pulmonary arteries in the upper lobes before you get to the level of the coronaries. The problem with the cranial to caudal acquisition is that you may lose the bolus to the lower lobe pulmonary arteries by the time you reach down, and that's where people advocate doing a caudal to cranial acquisition instead. In terms of contrast dose, you need an extended bolus of IV contrast. We talked a lot about contrast opacification this morning. And the reason is you want to opacify the systemic circulation and the pulmonic circulation at the same time with good opacification. So it's at least 130 cc's. And with that, you have limitations in patients who have borderline impaired renal function, patients who are older with comorbidities, you may not be able to give that amount of contrast. And to understand a little better, the peak contrast opacification of the aorta happens about 12 seconds later than the peak opacification of the main pulmonary artery. That's called the transient time. And you have this nice graphic by Dr. Khoury in 2011. And you start inject contrast, you have the peak opacification on the pulmonary artery. After 12 seconds, you're going to opacify, you have the peak of opacification in the aorta. That's when you want to start scanning the patient, because you want to have opacification of both systems. So after the moment you start scanning, you still have like 15 seconds to scan the patient. So you need to keep the pulmonary artery opacified for 12 seconds plus 15 seconds. So it's almost 30 seconds time bolus continues. Okay? That's why you need more contrast. And there are ways of calculating how much contrast you need. Shapiro published this in 2008 on AJR, when you get the time to peak enhancement in the PA minus the aorta peak enhancement plus the scan length, you multiply by the injection rate, usually it's 5 cc's, and you get how much you should give that specific patient. Because of the scan length, if the patient is smaller, you're going to get less coverage, so it's going to be a faster scan. And on his paper, the average was about 135 cc's total dose anyways. Johnson published this in 2007 when he gave you a table. So if you know how long the scan is going to last, let's say it's going to last 20 seconds, so I know I have to give 140 cc's at a rate of 4.5, and most of the time I'm pretty sure to get opacification of both circulations. With the new scanners, things are getting a little better. So if you have a 128 slices multi-detector CT, you can use a high-pitch spiral image acquisition and leads to a 10 times shorter scan time, which then you can decrease the amount of contrast you're giving. If you use a 320 slice multi-detector CT, it's even faster, so you can lower even more your contrast bolus. With the dual source, the same thing. It has a high-pitch mode that allows faster acquisition, so you can use less contrast. And the good thing about dual source, you also have less radiation. In terms of injection, you can do a single injection. When you only give undiluted contrast, 130 cc's, you trigger in the aorta, and this 5 seconds delay is to fill the coronary arteries. You can do a biphasic injection, like it was discussed this morning as well, where you do a first phase of undiluted contrast, followed by a second phase of contrast mixed with saline. And the idea is to keep the opacification on the pulmonary artery, on the right heart, without having a lot of streak artifact from the SVC over the RCA. There is also in the literature the triphasic injection. I don't see much difference from the biphasic, but it's undiluted contrast, diluted contrast, and I guess they do an extended saline chaser to really clean the SVC. Just have to be careful with that a little bit, because if you go too late, that saline, pure saline, is going to be on the pulmonary artery, and you're going to get a non-diagnostic PECT, so that's not going to be a triple rollout either. In terms of ECG gating, we have prospective and retrospective gating. Prospective gating, you're going to acquire only a part of the cardiac cycle. Retrospective gating, you acquire the entire RR interval, and afterwards, you're going to reconstruct the images. The retrospective gating is better because it allows you to do a faster scan, so you can give less contrast. It's also less dependent on the heart rate stability of the patient, but as you all know, it's going to lead to a much higher radiation exposure, and that's, if you were to use retrospective, you have to use tube current modulation on some sort of technology to decrease the radiation. And the tube current modulation works is that depends very much on the heart rate. So if you have a low heart rate, 60 or less, you should be able to use the full dose only in 60 to 7% of the RR interval. But the moment the patient's heart rate goes up, you increase that high dose period, and if it's more than 7, it's almost the entire RR interval anyway, so the radiation is going to go up. That's why it's important to beta block the patient if they can, of course. So that's an example, a patient status post-aortic valve replacement. We did an unenhanced CT first. We thought the patient may have a lot of calcium in the coronaries. She did not have that. Then we do a bolus timing in the ascending aorta, and that's the result. You have almost 400 Hounsfield units of opacification in the ascending aorta and more than 400 in the main pulmonary artery. Those are the images from the study. You have sharp aorta, no motion whatsoever. You have a good opacification of both chambers, right and left. You see the left main, proximal LAD, the right coronary, no streak artifact, and all the way to the bottom, end of the RCA, beginning of the PDA. Those are reformatted images. You have the LAD straightened out there, the circumflex, the RCA, and also the PDA in the bottom of the heart was well opacified, no motion. The problem of that is, so in this case, we did a retrospective gated, and we also did a non-contrast CT first, and we went all the way through the abdomen. So the total effective dose was almost 33 millisievert. The chest CTA itself contributes most of it, it's 27 millisievert, because it was done retrospective. Another case, another triple rule out, the patient had a very stable heart rate, so we went ahead and did a prospective gating. You have also, you can see here, it's almost 400 in the aorta, almost 500 in the main pulmonary artery, and the dose is much better. So you have 17 millisievert total effective dose, and the chest CTA part, since it was prospective, it's only, or it's much less, 11 millisievert. And just for comparison, if you do a non-gated CT of the chest, let's say you want to look for PE and dissection, you can do the same thing. You're not going to be able to look at the coronaries because of the motion, but your radiation dose is going to be way less, like 2.4. It's just a plain chest CT. And what we do differently, extend the bolus to get opacification of both circulations at the same time, but it's not gated. So every time you're doing a triple rule out or any CT, you should have quality control to look for the diagnostic quality. Make sure the radiation exposure is kept as low as possible, and pay attention to the contrast load you're giving to also keep it as low as possible. Diagnostic quality, we know that coronary artery opacification strongly correlates with the rate of injection and the concentration of iodine. So you want to make sure your patients have a good peripheral IV that you're going to be able to inject 4.5 to 5 cc's a second, the rate of injection. And you want to use 350, 370 concentration of iodine. In terms of cardiac motion, you don't want that at all, so make sure you position your leads correctly. You may have to go in the room. What you want is to have a very sharp, tall R wave peak, so the scanner can perceive when the R wave comes and can acquire in exactly the same place. Also keep an eye for streak artifact. If you're doing a uniphasic injection and you get a lot of streak artifact that is precluding your evaluation, either for PE or for the RCA evaluation, you may want to try a biphasic or triphasic injection. In terms of radiation exposure, things that we may do to reduce that, this morning we had a lecture on that already. You can try to reduce the field of view. Some people advocate excluding the apices, since pulmonary embolism is not that common in the apices. This is not a lung CT screening, so you don't really need the apices, but they may happen. So it's all a weighting of benefit and risk. If you have a dual source, that's better. You can reduce the dose to 8 to 15 millisieverts. Prospective ECG gating is going to reduce the radiation, but be very careful because you have to have a very, very stable heart rate. If the patient has any variability on that, you may just lose the whole thing. Retrospective gating does not depend as much on the stability of the cardiac cycle, but you're going to have a much higher radiation exposure. So you have to make sure to use tube current modulation or any other things that may reduce, like was discussed this morning, such as automatic exposure control, increase the pitch. Like we heard this morning, if you cannot increase the pitch that much when you're doing a coronary CT because of the gaps that may happen. You can use noise reduction reconstruction techniques, and every time you're going to decrease the dose, we know if you decrease the KVP, it's much better in terms of it's exponential. It's not like linear relationship like the MA. But the problem is you want to keep the KVP close to the K-edge of iodine, so we don't really advise going lower than 190 KVP. You're better off changing the MA. In terms of contrast load, we need an extended contrast bolus to achieve adequate concomitant opacification of systemic and pulmonic circulation. We keep in mind that the peak opacification of the aura is 12 seconds later than the pulmonary artery. And if you have a faster scan time, you're going to require a smaller dose of contrast, so you have to work around that. You can try to do a prospective gating or use faster scanners. So if you have a patient who is older but has an impaired renal function, so you're more concerned about the kidneys rather than the radiation so much, so you can decide to do a prospective gating rather than retrospective gating and give less IV contrast in that case. So you have to tailor for each patient. What you have in the literature about triple rule out, Mather published this paper in 2011. He retrospectively looked over 2 institutions in more than 2,000 patients. They're all low risk for coronary disease, and he correlated triple rule out and coronary CTA. They used both a dual source and a 64 detector scanners. The composite diagnostic yield and the presence of obstructive coronary disease was not significantly different between the two groups. They did found more pulmonary embolism in the triple rule-out group, which is expected because you are including that in your differential diagnosis. Surprisingly, they did find some in the coronary CTA group, and there was no aortic dissection on either group. The radiation exposure was higher with triple rule-out compared to the coronary CTA, as we know it would be. But interestingly, the patients on the triple rule-out group had more subsequent cardiac evaluations, and they had more repeat CT with PE protocol. So the conclusion was that triple rule-out resulted in high radiation exposure compared with the regular cardiac CT and was not associated with improved diagnostic yield, did not reduce clinical events, and did not diminish downstream resource use. Another paper published by Rogers, also in 2011, was a randomized diagnostic trial comparing the efficiency of triple rule-out versus each dedicated CTA, coronary, PE, CT, and aortic dissection. They had 59 patients, and they used a dual source 64 detector, and they did follow these patients for 30 days. They found that triple rule-out led to improved efficiency of treatment of patients with acute chest pain and low to intermediate probability of having acute coronary syndrome. There was no difference in the median length of stay, in the rate of hospital discharge without further imaging, in the costs of care, or the number of revisits. And they had a similar radiation exposure because he was using a dual source. The conclusion was that triple rule-out did not reduce the length of stay, the rate of subsequent testings or costs, and should not be used routinely with the expectation that will improve efficiency or reduce resource use. The third paper I thought was interesting is by Takakua, also in 2011. It was a prospective observational cohort study with ED patients over a period of 16 months. They compared triple rule-out with nuclear stress test, and it was more like a time cost analysis. They had more than 800 patients, and they conclude that patients in the triple rule-out group reduced the length of stay and image time, but they had a higher imaging cost. So in conclusion, triple rule-out ECG-gated chest CTA can differentiate between the most common life-threatening causes of chest pain and can define an alternative diagnosis. It's essential to have careful patient selection, since most of the patients who come to the ED with chest pain, they would rather benefit from the dedicated CT, either a coronary, a PECT, or a dissection protocol, which much lower radiation exposure and much less contrast dose. If you are doing a triple rule-out, make sure you need the right scanners, the technologist trained, a physician trained to read the coronary CTA portion of the study. The triple rule-out has to be able to give the same quality of each dedicated CT, otherwise there is no point of doing it, with acceptable radiation exposure and acceptable contrast dose. And we do need more scientific support showing that the triple rule-out has the same or improved short and long-term outcomes as each dedicated CT with same or lower costs.